Examination of patients with ophthalmologic problems should be done systematically using the 5-point ophthalmologic examination. This consists of 5 separate clinical tests that should be done in the proper sequence. The parts of the 5-point ophthalmologic examination in the correct order are as follows: visual acuity, gross examination, extraocular motility, tonometry, and fundoscopy. The key to proper examination is understanding what each part is testing and how it is properly done. Take note that you will frequently encounter these abbreviations as you study ophthalmologic examination. Determination of the distance visual acuity, or VA, is the mandatory first step in the 5-point ophthalmologic exam. Test one eye at a time by properly covering the other eye with an occluder. The Snellen's chart is one of the most commonly used distance vision tester chart in eye clinics. It is made up of 8 rows or lines with letters called optotypes. To determine the visual acuity, position the patient 20 feet or 6 meters away from the Snellen's chart. Test one eye at a time by occluding the eye that is not being tested. For example, a patient was able to read optotypes correctly until the 4th line. This line has a corresponding value of 20/50, which means that the patient was able to read at 20 feet what a person with normal eyesight could read at 50 feet. Check the vision on the right eye first. Record the line that the patient can read without any corrective lenses. If available, repeat again using corrective lenses and record the visual acuity. If the vision is worse than 20/20, record the vision and proceed to testing with pinhole vision. Your visual acuity findings should look like this. If the vision is not improved with pinhole or corrective lenses, you may write NIPH. Don't forget to occlude the eye not being tested and avoid unnecessary pressure on the eyeball, which may temporarily blur the vision. If the patient makes a mistake, continue with the next line until she cannot read at least half of the letters or optotypes. For example, if more than half of the letters or optotypes on 20/40 was accurately read, it is recorded as. If less than half of the letters was accurately read on the 20/40 line, for example, only 2 letters, we record it as 20/50 plus 2. For patients with low vision, if the biggest optotype on the first line cannot be read at 20 feet, ask the patient to move closer until she sees only the biggest optotype. Double-check by asking the patient to read the second line. If she is able to, she should move further away until only the biggest letter can be seen. For example, the patient was able to read the first line only after moving 10 feet forward. She is now standing 10 feet away from the chart. This means that the patient can only read at 10 feet what a person with normal eyesight can read at 200 feet. If the patient still fails to see the biggest optotype at 5 feet from the chart, the vision is then tested by counting fingers from about 3 feet away from the patient's face. The test distance moves 1 foot closer at a time until the patient correctly counts the number of fingers being held in front of her. This is recorded as CF for counting fingers and the distance at which the patient was tested. If the patient fails to see and count fingers, vision is tested with hand movement. Test the vision using hand movements and by light projection. Slowly wave your hand about 6 inches away from the patient's eyes. Ask the patient to report if he can perceive the hand motions. This is followed by vision testing using light projection. Using a pen light, shine a light from all 4 quadrants. Instruct the patient to point to the direction of the light source. Take note of the number of quadrants that are correctly reported by the patient. The vision with hand movements and light projection is reported as follows. If the projected light cannot be perceived from any of the quadrants, check for light perception by shining a light directly in front of the eye being tested. Perception of the light is reported as positive light perception, or LP. If no light is detected, it is reported as no light perception. Please do remember to always make sure that your reporting of the visual acuity is accurate, as this will relate to the visual prognosis. Also, make sure that the eye not being tested is covered well with the palm of the hand or closed fist, especially when testing for light projection and perception. In summary, the following is the sequence to determine the visual acuity score. We only proceed to the next phase in the sequence if the patient fails to perceive the visual stimulus presented, like letters or optotypes in the Snellen chart, counting fingers, hand motions, or light source. Near vision testing is done for patients more than 35 years old or patients who complain of blurring of vision at near distance who may already have presbyopia. Testing is done with both eyes open or unoccluded. The near vision chart is held in good illumination at 14 inches away from the patient's eyes. The patient is asked to read the lines from the biggest characters down to the smallest line. A corresponding near vision score is assigned per line, and in this case, it is reported as Jaeger 10 or J10 at 14 inches. The next step is the gross examination. You will need a handheld light source for this. To be more systematic, perform the gross examination of the eye by examining from outside going in. Follow this sequence. By convention, the right eye is examined first and then the left eye. Your gross examination findings should be recorded and labeled accordingly on a diagram similar to this. Describe findings or draw lesions as necessary and include measurements if possible. The structures that should be examined first are the eyelids and eyelashes. Take note of the upper and lower eyelid positions. Check for presence of eyelid lesions, discolorations, visible and palpable masses, and deformities. Check for alterations in the normal eyelid architecture. Eyelashes should be inspected for distribution, direction of growth, presence of crusting, nits, or matting. Record your findings on the gross exam diagram and draw as necessary. Next, examine the conjunctivae and the corneas. With the use of a pen light, check the bulbar conjunctiva for masses, lesions, discolorations, lacerations, vascular injections, and foreign bodies. Retract the lower eyelid and invert the upper eyelid to inspect the tarsal conjunctiva for conjunctival reactions, discharges, or any foreign body. The corneas should be inspected with a pen light to note for any lesion, ulceration, surface defect, or foreign body. Record your findings on the gross exam diagram and draw as necessary. Take note of the spots where the corneal light reflections fall as you shine a pen light directly in front of the patient, about 1 meter away at the same eye level. On your gross exam drawing, mark these positions with an X. Proceed to the innermost aspect of the gross examination. This includes the pupils and the lenses. Instruct the patient to fixate at a distant target. Start the pupillary exam by estimating the pupil size in millimeters. Then elicit direct pupillary light reflex as shown by constriction of the pupil upon exposure to a light source. Consensual pupillary light reflex is elicited when the pupil of the opposite eye constricts upon exposing the other eye to a light source. Pay attention to the symmetry and briskness of constriction. The findings of the pupillary exam are recorded as shown. Lastly, inspect the crystalline lens of the eye. These are found in the areas immediately behind the pupillary aperture. Using a tangential light, check for any lens opacities. Record your findings on the gross exam diagram and draw as necessary. When testing for extraocular muscle movement, the examiner should be at eye level with the patient, standing about 1 meter or 1 arm's length directly in front. The version test is done with both eyes open. Instruct the patient to follow your index finger as you move it in the 6 cardinal positions of gaze. Extend your arms to ensure that full ranges of motion are being tested. Note if the eyes move equally and in full range, and record findings as described later. If the versions are abnormal, perform the duction test. This is done one eye at a time. Use an occluder to cover the eye that is not being tested. Perform the same steps as described for version testing and grade the movement from 1 to 4, with 4 being full movement. The fourth part of the 5-point exam is palpation tonometry. Instruct the patient to look down without completely closing her eyelids. This way, you are ensured that you are pressing on the scleral aspect of the eyeball and not on the cornea. Next, rest both index fingers on the closed eyelids and alternatingly, gently press the fingertips and feel the softness or firmness of the rebound as it indents the eyeball. Estimate the firmness as similar to the following structures. Record your findings as follows.
In performing direct fundoscopy, first check that the light source is on and use the largest diameter circle with lens setting to 0. Remember to use your right hand and right eye to examine the right eye of the patient and vice versa. Adjust lens power to correct for errors of refraction. Perform the examination in a dimly lit room and the patient in a comfortable seated or standing position. Remember to direct your patient's gaze at a distant target across the room. Start 1 foot away from the patient and locate the red-orange reflex. Slowly come closer at 15-degree angle, temporal to the patient's line of sight. You may lift the patient's lid with your other hand. Start 1 foot away and locate the red-orange reflex. Adjust the focusing wheel to bring the retina into focus. When a retinal vessel is seen, follow it nasally until the optic disc is seen. Once you locate the ROR, slowly move closer to bring the retina into focus and locate the retinal vessels. Examine the optic disc, retinal vessels, retinal background, and macula. Findings are recorded in this manner. The red-orange reflex should be evenly colored with no shadows. Check for any opacities in the lens or cornea. Locate the optic disc, which is yellow-orange in color. Note the disc borders, which are well delineated in this case with a CD ratio of 0.3. The cup is a central depression in the disc. Normal CD ratio is less than 0.6 with less than 0.2 asymmetry between the two eyes. Normal AV ratio is 2:3. And remember to check at the second branch. The normal retinal background is red-orange in color with no hemorrhages or exudates. Check for retinal detachment and check the fovea light reflex by asking the patient to look at the light, which is reported as a good fovea light reflex. Again, remember how fundus findings are recorded.